Hi everyone, we're Chris, Raymond, and Kevin from the University of Sydney. All of us study in Bachelor of Medical Science. Today, let us take you through the journey on how to improve the refugees' overall well-being. Our presentation will be broken up into 4 parts. First, I will first discuss our targeted populations and what barriers they're facing, also addressing the timeline of our projects. Then, I will pass the time to Kevin to introduce our program objectives and what activities we're organizing. Finally, Raymond will justify our programs and also sustainability of the programs. In 2021, Australia granted a total number of nearly 6,000 refugee visas, which is continuously increasing in these years. Most of these people come from Iraq and other countries in the Middle East. Therefore, our targeted population of our project is the Middle Eastern refugees. The Middle East refugees found it difficult to work and be self-reliant when they arrive in Australia. The barriers may include temporary visa status, lack of recognition of overseas qualification, financial handicaps, unfamiliarity with the new area, and limited English skills. Language barriers are considered the biggest issue that needs to be focused on. Moreover, mental health is a top health concern for these Middle Eastern refugees. Due to the language barrier, those refugees are suffering from bullying and discrimination, which cause huge harm to their mental health and bring them loneliness and helplessness.
It is one of the most important things you can have.
To access services.
To access services, to protect yourself, to have a future, to have a better life. You need language.
This is our timeline. Our project assumes the refugees has already arrived in Australia for half a year, and the accommodation, clothing, and food are all sufficient. The first step of our project is home visiting, and the main purpose is to develop a reliable relationship with them. After the home visiting, each member of the family will have an individual case management team, and these plans will help the family achieve outcomes such as improving their English skills, finding long-term accommodation, participating in local community events, and engaging in education, training, or employment. Our second step is to bring them to our local hub to introduce the hotline and the GP services we included. One thing that is good about our GP services is that the doctors we hired are bilingual, so they can communicate with the refugees directly. Moreover, we also provide them with 2 English lessons per week to improve their English skills and also organizing cultural activity per month. Last but not least, it's very important that our staff will follow up their attendance rates in every half a year, and this project is lasts for 4 years. Now, I will pass it on to Kevin to explain our program objectives and our activities.
Here, I will introduce our program objectives and activities. Our comprehensive plan aims to establish long-term relationships with the Middle East population of refugees in Sydney, encouraging them to access free basic healthcare services. By addressing the barriers to healthcare-seeking behaviors and fostering trust within the community, we can ensure continuity of care, prioritize preventative care, mental health support, and the management of non-communicable diseases. This plan emphasizes cultural relevance, effective communication, and sustained engagement with the target population. For our activities, we consider to establish partnerships with the local community-based organizations, refugee support networks, and non-governmental organizations experienced in working with refugees or relevant. Leverage their existing networks and infrastructure to identify and connect with the refugee population. Also, by developing a dedicated multilingual hotline staffed by bilingual healthcare professionals and cultural mediators to provide information, support, and referrals. This hotline would serve as a primary point of contact and a reliable source of healthcare-related information. Furthermore, it would be ideal to deploy mobile healthcare units to refugee settlements and community centers, providing on-site basic healthcare services, health education, and immediate assistance. These units would enable direct interaction and build rapport with the refugee community.
Our community's local hub, telehealth service, and health resource companies all aim to target the different needs of the refugees. I will first explain how these three programs can help to improve their healthcare needs. Then I will briefly introduce our budgets and how the money can be fully used well. The community's local hub helps the refugees to gain confidence. Talking to people who are from the same cultural backgrounds can increase the chance to reach out. The local hub can act as a suffering for them they are no longer lost, and all the required health information can be accessed in this hub. We have a local GP in the hub as well. The GP either know how to speak their local language or an interpreter was hired to help. If coming to this hub by public transport is challenging, we offered telehealth service as well. All the refugees needed was a telephone, and they could call the GP to ask any health-related questions. This service is specifically tailored for the refugees because the community might also be one of the main challenges of the refugees.
With the use of telehealth, I've noticed that our refugee patients really like the impact that giving them the call or initiating the call to do a video call really seems to help them feel cared for and thought of.
Apart from providing health consultation, it is very important to raise awareness of different diseases, and prevention is better than treatment. Our podcasts or programs in the hub invite health professionals to explain and potentially correct methods. We will try to invite health professionals who had a very tough upbringing because this would narrow the distance between them and the refugee, and hence increase the likelihood of the refugees listening to them. Now, I would like to introduce our budget, which is summarized in this slide. The total staffing cost would be $100,000, and the total arbitrage and the logistic cost would be $14,000, and the total technology cost would be $20,000. The method for keeping communicate with patients after they have visited the GP would be regular phone calls or home visits by our staff, and if the staff found the issue with the patients, then a special team formed by a doctor and a translator would visit the patients in their home and give professional advice.